Yeah, very clearly.
Good afternoon,
Good afternoon.
Srinivas. Welcome to Jayadeva Institute of Cardiology. I am Dr. K. Srinivas, and on my left is Dr. B.C. Srinivas, and we have our CAT team with Chief Technician Mr. Mohan and his team, and the staff nurse Dr. Mrs. Saira and team, and we have our anesthesia colleagues who have helped us in organizing the cases today. And we have two cases lined up for you. The first is a case of inferior vena cava obstruction. The second is a case of central venous obstruction in a patient with CKD and maintenance hemodialysis. And before we go on to the cases, we just want to give a feedback on the last year's case that we transmitted. We were not able to complete the AVC angioplasty and stenting. There was a slippage of the stent. How we handled it, we'll just show it to you with the presentation, and then we'll move on to the live case proper. Can we have the presentation, please?
Next slide. This was a 46-year-old male who had presented with IVC syndrome. Next. So this is the clinical picture. He had prominent veins over the trunk and the lower limbs, and there are marked changes in the legs, as you can see, depigmentation. Next. Okay, and this was the CT picture. He had a calcified web in the hepatic segment of the IVC. Next. And you can see that there is a pseudoaneurysm adjacent to the calcified web. Next. And in fact, this was the first case of balloon angioplasty of the IVC we had done in the institute way back in 1995. This was a web, as you can see, simultaneous injection above and below the level of obstruction shows a thin web. Next. So this actually we had used a broken bone needle to cross, and then dotted with that particular time. What had happened, as you can see in the first frame, there is extravasation of contrast during initial broken bone needle puncture. But successfully we could cross the web and then dilate with Inouye balloon and get a good result. Next. So this time we had come with a restenosis with a pseudoaneurysm. Pseudoaneurysm was exactly at the site of where the needle puncture of the inferior vena cava wall. Okay, this is the picture you can see. That's a AP and lateral view. There is a with a web and a pseudoaneurysm you can see there. Next. So we crossed that with a multipurpose terumo, and then next, pre-dilated with a Inouye balloon. Next. Okay. This was actually a residual lesion you can see on the first frame. We mounted a PS5014. This was on an Atlas balloon. Unfortunately, next, what happened was the stent got milked towards the right atrium. And we had to retrieve that stent back into the site, or we had to do something else. The panel at that particular time had given us options of, number one, to take that stent up into the SPC and deploy it. That was one option. So other option was to crimp the stent on the wire or on the balloon and either take it out or reposition and then deploy it in the hepatic segment. This was the thing. So at that particular time, we had lost the transmission. Go to the next. So what we did, first we wanted to secure that particular stent with another wire. Next. So we passed another 035 wire through the stent and then grabbed it from the SVC, and then so we had a veno-venous loop between the jugular vein and the right femoral vein, so that we made sure that the stent which was displaced were on two wires. Next. Then we took a balloon, tried to partially inflate and take it down. That was not possible. Actually, it deployed the stent partially, the lower end you can see. Next. Next. So what we did was we brought a filter, you can see in the second frame, And then that filter, we have put it over the
Snare.
so the snare, I mean snare. We tried to use that snare and crimp it. Next. So next. We did manage to crimp it on a balloon partially and then pull it down to the IBC. Next. And then deployed it. The snare unfortunately could not be unhooked initially. Next. So what we did was we used the snare, with the broken snare was retrieved with a biopsy forceps actually. Next. We ultimately post-dilated the stent with the Acura balloon. Next. And this was the final result. You can see that the web also was treated and the pseudoaneurysm also was gone, as you can see. And he is doing well even now. So this is the feedback of the last year's case, which we could not complete at that particular transmission.
Okay. That was very interesting, Dr. Srinivas. I was just thinking about last year, we just wanted to see this and we lost the transmission. What if you had taken this stent up to the SVC and deployed it there? That would have been, I think, more simpler and put another stent in the IVC.
Easier option, actually.
True.
That would have been an easier option, no doubt.
Could have done that.
But it's very, skilled operators like you can do this, but I think most of the operators won't like to do this.
Okay.
We'll go to the first case.
Shall we go to the case, today's case?
There is a question in the audience about this.
Mounting of the stent over the non-compliant balloon is more likely to happen. I had similar case, but managed to put the stent in the right place. But it is better to mount on some semi-compliant balloon and then put the stent, and then you dilate with the non-compliant balloon. Because Atlas is a non-compliant
Absolutely,
balloon.
I fully agree with it.
Yeah.
And
yes.
I think the other good choice would be a
balloon in balloon. A new balloon also.
Maybe a balloon in balloon is a good choice where you can crimp these stents on a big balloon and then the slippage won't happen.
Yeah, that balloon technique is a really good method to avoid the slippage of stents. If you see before deployment also, it has moved a little before on the markers on the balloon. I think we'll go to today's case.
Yeah, you're right, Srinivas.
This was again a case of IVC obstruction which we chose. Next. This is a 32-year-old male who presented with progressive swelling of both lower limbs and abdominal distension with engorged veins over the abdomen, back and legs. Next.
Okay.
He had presented with similar features in December 2002. At that time, he had a membranous IVC occlusion and he had undergone a successful angioplasty at CMC Vellore in 2002. This was the picture in 2002. You can see that there is a thick membrane in the hepatic segment of the IVC. Next. So they had done a balloon dilatation with a good result actually.
I'll leave it.
In fact, this is our policy also. Next. At present, he has presented with similar symptoms of about 3 months duration now. So the initial balloon dilatation has lasted for a decade. Next. You can see that there are prominent varicosities in both the lower limbs and dark pigmentation over the skin in the legs. Next. And you can see that the CT we did here actually shows a large clot below the level of obstruction. In fact, we received the images today morning. So what we did, we took him up for cath. Next. Next. Show the fluoro. Fluoro, please. So we had a right jugular approach and the right femoral vein approach. You can see that the multipurpose has come from the right jugular vein and the pigtail we have introduced. And in fact, it is a membranous obstruction because it's a narrow segment, you can see. So it is a restenosis. But you see the IVC carefully, there is a large amount of clot burden, you see that. Clot burden. So that is the issue. In such a scenario,
How should we go?
How do we go about? I want the panel to discuss this issue.
I think we have Dr. George also with us. Do you remember any collect this case?
Yeah, this is a lot of thrombus. We would electively thrombolize for a couple of days before we open up that web and reduce the thrombus burden. I think that would be a safer way to do it.
Yeah, we would agree with you.
Yes, I fully agree with you, Dr. George.
Okay.
Next. Collins, what would be your strategy in this?
Yeah, I mean, I think it's just an elective case, and the other option would just be to anticoagulate the patient for a while. I don't know if it's anticoagulation status. Was he chronically anticoagulated?
Go back.
Dr. Srinivas, there is a question from Thai, whether this patient was anticoagulated preoperatively.
No.
No, actually, he has come to us 2 days back. We have taken these pictures now. Now, actual plan is we have abandoned this case in view of the large thrombus burden, because I fully agree with Dr. George. This has to be lysed for 48 to 72 hours. The clot burden should be brought down, and then only we should intervene. But intervention should be easy. I'll show you. Next. You can see that I tried to cross and show that it can be crossed easily. Next. Okay, that is we have actually initially it went into one of the collaterals, and you can see that now we are in the right track. Okay, just to show that we can cross and treat this lesion easily. But at this stage, we have abandoned this, and I am lysing this for the next 48 hours, and then taking him up and then stenting that particular segment only.
Like non-invasively.
If we do it in this setting, see, you'll have to use it. Yeah.
Is there any role of a thrombectomy at this stage?
No, it is such a large thrombus burden. I don't think.
Or maybe a combination of thrombectomy and lysis, catheter-directed lysis.
See, best will be to,
Best would be catheter-directed lysis for 24 to 48 hours, then review the situation and complete the procedure.
Another way is there are case reports of using closed cell design stents.
I think we lost the voice.
That is another option, but I don't think
if the
we
clot
should do
burden
that.
is small, we can do that.
I'm not aware of any
And in fact,
effective thrombectomy device for an IVC that's close to 4 centimeters. You know, it'll just move here and there, but you're not going to effectively clear that thrombus. I don't know if there's any device like that.
Tai, do you think angiojet poses is going to work here?
Probably not the angiojet. This is probably a chronic organized thrombus. That's what I was asking about, whether or not the patient had been chronically anticoagulated. So you could treat this, I think, probably more similar to a PE with one of the ultrasonic thrombolysis catheters, either the ECOS or Trellis system, if you have that available. And you may get more thrombolysis or more, resolution of some of the thrombus. But the problem with thrombolysing this is that you have so many runoff vessels there that with just a typical end hold or even a multi-site hole catheter, you're going to bathe just the outside of this thrombus, and it's going to take more than 48 or 72 hours to clear it up.
Do we have a trellis device in this size to take care of this clot? A trellis where you can have a balloon occlusion and a localized lysis?
Yeah, I mean, it's almost occluded, but I think there's enough runoff there that you're going to have the thrombolytic agent, going everywhere. But I think at least with the, the trellis device, in theory or mechanistically, you may get more, thrombolysis. This looks more like a pulmonary embolism as opposed to a DVT that you would see, in a deep vein.
Right.
Can you suck the thrombus with 12 French guiding seat, 12 French seat with attaching with the suction catheter, suction machine?
Now this is too large a clot. This is too large a clot for any of the devices.
No, 12 French seat with a side port and then attach it to the suction machine, which we use suction for the throat and all.
Anyway,
that.
definitely when you have seen it pre-procedure, we won't have tried all that. But having gone inside, people are suggesting whether you could take help of some mechanical thrombectomy if it works. Non-invasively, when you do the echo, did you find any evidence of thrombus there in the IVC? I think the huge thing you should have picked up even in...
Image was bad.
No, now what can be done?
Was not good.
Yeah,
you can
now
use 12 French seat or 10 French seat and through the side port of the seat, you attach it to the suction machine and then try to touch the clot and with the angiography and suck it.
But the problem there is that you lose a lot of blood if you do that.
That you can replace with the blood and then you can put
we lose a lot of blood.
And you still may not be able to take out a lot of blood.
You can't direct that sheet onto the
thrombus. We may not effectively clear it. Yeah.
Well, I think there are two questions. So this is a man who was treated before?
I think
he had his IVC open before?
Yes,
he had angioplasty
it was
before.
done in 2002.
Okay, so since 2000.
And then it was attempted 2 weeks ago, actually.
Okay, but I don't think you suspect that this is something that happened 2 weeks ago because he's occluded. I think the thrombus on top of a chronic stenosis or occlusion is what tipped him over. And so, just simple thing like anticoagulation may be enough to resolve this clot and maybe enough to get rid of some of the symptoms.
True. And then come back and then, Yes.
Okay, in the interest of time, we'll move on to the next case so that we have to also demonstrate another case of transseptal puncture subsequently. So we will go on to the second case, which is a central venous occlusion. I think we can have the slides, please.
90s, whichever cases reports were done for the IVC obstruction, there were reports of sudden death first 24 to 48 hours following balloon dilatation of the IVC obstruction. All of those cases were due to the thrombi which were not recognized below the level of obstruction. Once they cleared the obstruction, the clot which was below the obstruction embolized into pulmonary circulation and killed the patients. So this is in fact, important message I wanted to pass it on in this particular case.
And all the cases that we have lysed till today, we have got an effective lysis, and we have been successfully, we are able to perform the angioplasty and stenting subsequently 24 to 48 hours later.
Slides? No, slides. This was a 56-year-old male, 61-year-old male, diabetic and hypertensive for the past 25 years, who has chronic kidney disease with CRF. He is on maintenance hemodialysis. 12 months back, he had a right brachial AV fistula done, which that particular upper limb has got severe swelling at present with, for the last 1 month. And in fact, he has a CT venogram which revealed a total occlusion of the right innominate vein. You can see that there is a gross swelling of the right upper limb. And the CT venogram showed that there was a total occlusion of the right innominate vein. It's a fairly long segment total occlusion of the innominate vein. Next. Come to the fluoro, first shot. So in these cases, what I do typically is I access the right femoral artery, right femoral vein, and then try to get into the right subclavian and take an injection and do a fistulogram. And here you can see that the right subclavian artery injection done shows that there is a filling of the subclavian through the right cephalic vein, and there is a total occlusion. Freeze. So you can see that there is a total occlusion of the right innominate vein, and the gap between the two, the SVC and the right innominate vein, is very long one.
2 vertebral width.
I want the panel to discuss the strategies, what should be done and how should we approach this case.
Freeze that on the screen. Yeah.
What is the presentation? I'm sorry. What is the duration of obstruction?
Almost.
Obstruction is about 1 month old.
So, I mean, the duration of symptoms is for 1 month. Maybe it was a tight stenosis and that got occluded.
Yeah, symptoms is one.
Yes, yes, yes.
Correct.
It would be much more. I fully agree with you, Dr. Khan. Yeah.
And Tai, what would you be doing in this sort of cases? You want to go via the femoral approach or directly puncture the outflow of the fistula and then go? Is it easier to cross from above or from below?
Yeah, when you look at the,
Yeah, but
I'm sorry, when you look at the subclavian here, you don't really see much of a stump to give you a direction to know where to puncture, but coming in an antegrade fashion, meaning antegrade in the vein, coming from the arm, looks like a more favorable approach. There's a large collateral right before the total occlusion, but I think if you use a little bit of cranial angulation when you do your angiogram, you may be able to separate the subclavian vein and artery a little bit better and see where the occlusion is. But a 1-month-old occlusion, I would expect to be able to cross that, with a wire. And then once that's done, do you want to thrombolyse it, or do you want to use angiojet, or do you want to just balloon it and stent it? I think you have a lot of options. What are you guys thinking?
So what's your strategy, Dr.
We'll show
Srinivas?
what we, yeah.
So what we have done, we attempted to look for a entry through the right femoral vein, but it was very difficult to cross this from the right femoral vein. So what I thought, to come to the top end of the lesion was the key thing. So when I looked at the entire anatomy, I thought the subclavian vein approach was the best for this particular case. So go next. So what I did was, next. So in fact, the catheter from the right femoral vein actually entered into the collaterals. There was absolutely no clue where the bottom end of the lesion was. Next. So what I did was I punctured the subclavian vein and got a sheath partially in. Next. So now I was at the top end of the lesion, very close to where I wanted to be. Now you can see that you can see a nipple at the top end of the lesion more clearly than before. So with this achieved, I thought the best way was to attempt from the cross the lesion from the top end and then try it. I was not sure whether I'll be able to cross it, but I tried. Next. So this is actually Cook's sheath, because Cook's catheter for a
Slip catheter.
slip cath with a angulated pterymo. Though I made an initial entry into the lesion, it was quite tough from there. It took about nearly 30 minutes to wire this lesion. Next. The wire wouldn't move beyond that point, and the Cook's catheter wouldn't go beyond that point. So at this time, what I did was to take out the Cook's cath and take a slip cath, the micro cath. Next. That is the slip cath beyond this point did not go in. So what I tried with a hard coronary wire, actually, even that wouldn't go beyond that. Then I took out and then tried this. Initially I had used the angle pterymo. Now I used a straight pterymo. Now the straight pterymo could make some progress. Next. Ultimately I could negotiate across the lesion, and then that's the wire in the right atrium, as you can see. With this done, we have snared out that wire from the right femoral vein. So exteriorize the wire. Now we have a veno-venous loop. Veno-venous loop in this scenario gives a very good advantage. Actually, you can push through your hardwares much more easily. Next. 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 Okay, we are at this stage right now. And now we are planning to balloon dilate the lesion and stent it. We have chosen a 14 into 6 maxi LD. That is the maxi LD. Okay. The advantage of having a veno-venous loop is you can actually, as you can see, you show here, you can actually, if there is a difficulty in, to push the balloon from here, you can actually withdraw the wire. You can see here. But one should be careful that it should not come out of the subclavian vein. Wait, small injection there.
Is there any risk of cutting through this angulation if you are using stiff wires? Because we have a veno-venous loop, and if you put more traction, you can actually sort of...
I have actually, yes, you can cut through, there is no doubt.
But it's extremely fibrotic, generally, chances are less.
We are in this right subclavian, the sheets is still in the subclavian, you can see that. Okay, it is.
Melon seeding. Some more volume, please. Selling some more over here.
Okay, just pull it a bit. It's okay?
Yeah.
Okay, then.
Okay.
What size balloon are you using?
This is a 14 millimeter.
14 into
bars.
60.
Fluoro.
And how about starting with a smaller balloon?
Save. Okay. I think we will go with a smaller balloon, yeah. Smaller balloon.
And once you have passed your wire, how are you sure it's not subintimal? And I mean, isn't it better to use a smaller balloon first and then go ahead and do a bigger balloon dilatation?
Yeah, I think a smaller balloon helps you.
We'll take a smaller
Number one,
balloon now.
because you may be able to cross it. You saw how difficult it was just to get the catheter across, so you know the larger profile balloon isn't going to cross easily. The second thing is, like you said, you may be subintimal, and with a smaller balloon, if he complains of pain, then that should be your signal that going to a larger balloon will have some risk, or you may want to consider using a covered stent before you go further.
Just show them. Maybe you can show to the camera. Yeah.
Sure.
We've taken this shorter balloon.
Mustang we have taken. Boston Scientific 6 into 60.
Okay.
The suggestion here was probably to
Hold
take
the wire
a
there.
smaller size diameter balloon and see whether it is expanding
shorter balloon.
and free from any false passages, and then take.
Yeah, we have taken a 6 millimeter balloon. Yeah.
This doesn't go, we'll take still smaller one here. We'll try with 6 mm. If we fail to cross, then maybe we'll take a still smaller balloon.
Yeah.
Is this a hydrophilic balloon or a...
I'm not very sure. Is it a hydrophilic balloon?
No, it's not. It's just a non-compliant.
Huh? And is it hydrophilic coated balloon? No, I don't think it is a non-compliant balloon. So the wire is yet to come here.
George, do you have a hydrophilic
Put
balloons
them
in peripheral? I mean, in this size, 6, 8, 10, from any company?
I'm not sure.
Not that I'm aware of.
Keep it straight. Keep it straight.
Yeah, it's come. Yeah, take it in.
So one other trick, if that doesn't go, because you're working over such a long wire, if you put the balloon over the wire coming from the arm as opposed to coming from the femoral, because you lose some of your mechanical advantage with all the laxity that you have in the femoral pushing upwards.
Okay.
Yeah,
enough.
correct. That's what we bet. Okay, I think we have managed to get across the lesion.
Okay.
Okay, I'm going up. Yeah. Sini.
Come down. Contrast. Just to give a give. Okay.
Turn it to the right.
Okay.
Now we'll take the other balloon.
Yeah, you inflate once again.
Yeah, you may want to advance just a tiny bit just to make sure you can cross.
Okay, come down.
Yeah. Right. Just
Be
inject now
careful with
and
the
see.
wire. Hold the wire.
Yeah.
Ready? Okay. ಇದು straight ಇಟ್ಕೊಡಿ.
Wait, no, where is okay, you're checking out it. ವಿಕಾಸ್ಗೆ ಇದು ಮಾಡಿಕೊಟ್ಬಿಡಿ. You want to just take a small check shot, just to see, just SSC?
Can check?
Yeah, fine. That's
Okay, you can see that there is a communication, and we are intraluminal.
Yeah.
At this stage, I mean, after you balloon, would you like to put a covered stent or a non-covered stent, or leave it without a stent?
No, I'll use a wall stent and stent this. Self withdraw. Sako, wait. Okay, wait. System.
No, ಸ್ವಲ್ಪ ಮುಂದೆ ಹೋಗಲಿ. Go in a bit more.
Enough. That will push out that.
Okay, maybe if you want, you can check and put it also. Shall I? Inflate?
Yes.
Keep it pushed.
Okay, it's okay.
Oh,
Go.
tough.
It's okay.
Go in again. Go in a bit more.
Okay.
Sheath back a bit.
Okay, now you go up.
Okay.
Up.
Yeah, we got it now this time.
It doesn't matter if it is an atrium or no, like this.
Oh,
Okay.
wait. I'll wait for some time.
It's very hard at that particular point.
Cutting balloon beneath. We'll wait for it while it many times heals with time. You just see.
This
Chronic
is
venous lesions are very fibrotic, and sometimes they take a longer time to heal, so we just leave it inflated for a slightly longer time.
Why don't you use a non-compliant balloon like
Slowly
the
release.
Conquest or the Atlas?
Okay.
Atlas is it?
Atlas ಇದೆಯಾ ಮೋಹನ್?
Could you keep it ready?
You have a 12 or 14?
This
12
will
you
wait.
give.
Maybe it will
12
wait
you
with
give.
this. We'll just keep for a while. And get the Atlas, please. Yeah. Fluoro? Oh. Okay.
At this size won't be there, but smaller one you can try initially.
Okay. Come down.
Do we have peripheral cutting balloons?
The largest is 8 millimeters.
Oh,
With
it
Boston
is yielding.
Scientific
Just
has.
wait for a while. Yeah, it is yielding.
So, I mean, as a strategy, if we can use it before and then post dilate, the first balloon could be, or second balloon could be a cutting balloon. Would it be easier to dilate those fibrotic lesions?
I think it's just a high pressure balloon will do the job. You need something like the Conquest, which goes up to 30 atmospheres.
I think when you look at the size of the waist in that balloon, then, even an 8 millimeter balloon
Go up
would
and
be
have it at the
large enough
center
to
so
maybe
that it
break
could be-
that. Because clearly it's not going to get to
Okay,
14.
Atlas,
So
please. Yeah.
anywhere from 8
Atlas
to 10 would
shorter
probably be
balloon,
safer than trying
Short.
to crank that 14 up.
40? 1620 you give.
Hold this.
We have a 1620 and a 1640. What do you suggest, Dr. George? 1620 or 1640?
No, go smaller. Do you have a 10 or a 12? Like a 1040 or a 1240, and go up to say
1040 do you have?
No, I don't
1240.
think we have a short balloon like that. 1620 we have.
That may be a little too big and it'll
40
melt
no.
in seat. It's just 20. It's not going
Yeah.
to be stable there.
I know.
No, 1440 we will take, Dr. George.
Okay, if that's the only
We
one.
don't have a shorter balloon, so we'll take a 1440 and try. Yeah.
Okay. Biಡಬೇಕು. Leave.
Yeah.
Okay.
Yeah. Sheet back a bit.
Sheet back. Okay.
I think that was the area.
That was the area.
Just show the previous image
Previous image, could you?
and have the road map here. Yeah. Set. Yeah. Okay. Show where we are. Just go up a little bit.
Yeah.
Yeah. Go up here. I'll deflate you, go in and then do it.
Hold it.
Go in. Go in a bit more.
Hold it. Okay, enough. Okay, go.
Okay, I'm inflating.
Hold it.
Hold it.
ಇಲ್ಲ, you have to hold. ಆ ಕಡೆನೇ ಬರೋದು.
Fluoro. Fluoro, please. Yeah, I think we'll start here. That will be better. We'll start here.
Okay.
Again.
Okay. Go slow.
6,
We are at 6 now.
8, 8,
Okay, 10.
10.
Yeah, now it is yielding. Okay, wait.
Wait.
What is the nominal pressure for this balloon?
Oh, this is actually, it can take up to 30 atmospheres.
So this is a non-compliant.
That is the advantage of the Atlas.
Right.
Yeah, non-compliant, yeah.
Now it seems completely open.
Okay.
Fluoro.
Come, yeah. Okay, you take the dilator.
Call one of our PGs talk readiness. ಆ level.
I think we need to.
Okay, well, what do you have? We'll take one angio before we.
What is the strength?
Wall
stents.
Just take a babu, ready for a shot?
6 centimeters, 7 centimeters.
90 millimeter.
So it is hanging into right here.
Little bit. It will just make it.
Dr. Srinivas, you're left with 2 minutes of transmission time, but I think you have a live lecture coming from there after. Is this thing you can again show after the lecture the final result? You continue with the case. Probably.
Oh, sure, definitely.
Fine, we could
we'll
do
give
that.
okay. So it is recanalized, as you can see now. We'll go with a stent in the meantime.
But this seems to be a very decent result. Do you still, Dr. Srinivas, why do you still want to stent this? It seems to be a very decent result. I mean, I would ask Ty or maybe Dr. George, do we really need to stent like in arterial side all the CTOs on the venous side, especially the central vein?
I would stent. This is a chronic venous occlusion, and if you just leave it like this, it's likely to close off pretty soon.
On the other side, there is some stent.
In fact,
that's okay.
the restenosis rates are very high.
With a stent or without a stent?
Without a stent.
Without the
Without
stent.
the stand.
With the stent, you can always go in, and even if there is a restenosis.
It will act as a roadmap for the subsequent intervention when we have a restenosis.
Yeah, but it's also going to go around a lot of tributaries which are draining there in the left innominate vein, because we will probably be coming all the way up to the SVC. And if you have a restenosis, you may actually get a problem, sort of dilating those and dilating the confluence of the veins.
90.
Especially in dialysis patients, because of this torrential flow, the risk of restenosis with stents are much higher. And a lot of data will suggest that stent only if it is required. And I believe if you take the gradient, there shouldn't be any gradient across the stenosis now. Tai, what's your take on this?
Yeah, I think it has a high risk of restenosis. And since it was a total occlusion and difficult for them to cross and to dilate, I would stent it.
Time's up, sir.
Dr. Srinivas, what is the stent? What is your further plan? What stent you are planning to take? Just tell us your plan, then probably.
We will take a wall stent now. Now we were debating on what length to take. That was the question. What size and what length? Any suggestions?
Yeah, take a big one, probably a 16, 18, or even a 20, and it should be long enough to go around the bend.
2055?
Yeah, that would be good.
What was the size of the balloon you used?
14, I think.
We used a 16 mm.
No, 16 in.
Oh, initially 16, then 14.
No, the length.
60.
So I think we should have something like a 55 or 60 or maybe 60.
Yeah.
Or 60 should be okay.
Yeah.
Even 80 should be fine.
We are planning to take a 20 into 55.
Yeah, that'll be plenty long enough. It's going to be constrained, so it's going to be longer.
Yeah. The important thing would be not to project too much into the right atrium. So the good thing about the wall stent is that you can release it till the point of no return, and then if you're not happy with the position, you can resheath it and then reposition and redeploy.
And what size of sheath would be required for a wall stent of this size?
I think 11 or 12 French.
Yeah.
12 is.
Yeah.
12 is good enough.
10 to 12 would be enough. Okay.
Contrast is there.
Contrast here. Okay, you can go ahead with the lectures. We will finish this and then show the final images.
Okay. Congratulations for excellent demonstration. I was told that new panelists will join again. We'll have Dr. Manjunath presenting about transeptal. Then afterwards we'll show your final result. Thank you.
Thank you very much indeed.
Hello.